strengthening healthcare quality. Strengthening healthcare quality through intentional leadership, a very timely topic for us this afternoon. And I really want to thank our sponsors. I want to thank KNH. I really want to thank Acquire. I really want to thank SQH just for coordinating this webinar for us this afternoon. My name is Jane Gifu. I'm the manager for quality improvement at the MP Shah Hospital, and I will be our moderator for this afternoon. So today we are looking forward to having three wonderful presenters present to us. We have three very good presentations coming our way, and I'll be taking us through each and every presenter as we move by. Our first presenter, as we move on, as I'll be introducing to you, will be Violet. And then we'll have her presentation from Sinaida Muluba. And lastly, we'll have our third presentation from Dr. Lucy Gugi. So I really want to invite you all for this webinar. Please feel free. And I know you might have questions as we move on. I really invite you to take note of the questions as the presenters take us through the sessions. Take note of the questions you might be having, note them down. We will have a Q&A session at the end of it, and then we will invite you to post your questions at the end of the chat. So if you have any questions, if you have any concerns, I really request you just note the questions down as the presenters take us through, so that by the time we are reaching the Q&A session, you might be able to raise your questions with us. So as I've mentioned, we have three presenters. Allow me to start an introduction of our first presenter. I just want to take you through the bio of our first presenter, even as we prepare to start our sessions for today. So our first presenter is called Violet Makoha. Violet is a senior technical advisor, quality improvement at SQH Kenya. Our roles and responsibilities includes providing technical assistance, coordinating and supporting implementation of CQI within SQH Kenya programs. She supports innovation and documentation of best practices to improve quality of care. She also coordinates and provides mentorship on utilization of continuous quality improvement digital platforms. She works in collaboration with the Ministry of Health and other IPs in quality improvement policy development, implementation, capacity building of service providers and managers. Previously, our presenter, Violet Magoa, was a CQI regional lead at the University of Maryland. She held several CQI positions within the University of Maryland. Also, SQH Kenya programs. I know she'll be telling us what SQH Kenya really is about. Implementation of in over 6 counties in Kenya. In terms of her credentials and education, Violet is a clinician with an MPH in epidemiology and disease control. She has over 14 years clinical work experience and 12 years of this majorly implementing HIV programs in Kenya. She is a member of SQH. She has several IHI quality improvement trainings. She is trained on monitoring and evaluation, leadership, economic evaluation, implementation of science from the University of Washington, a national TOT for quality improvement, and supported rollout of KHQIF. So team, I'm really excited this afternoon for us to proceed with our first presenter. Allow me and join me in inviting our first presenter, Violet Magoa, to take us through the first presentation. Welcome, Violet, and thank you for being here with us this afternoon.
Thank you so much for the introduction. So my name is Violet Makoha, as I've been introduced, and I work with SQH Kenya. SQH stands for Center for International Health, Education and Biosecurity. It is a local NGO that implements HIV programs from prevention to treatment and key population and even REMS programs. and it has a footprint in quite a number of counties, beyond 10, implementing care and treatment programs. So I serve as the Quality Improvement Senior Technical Advisor for the program as at now. Allow me to take you through this very wonderful topic, and thank you to Acquire, the Society of Quality Healthcare in Kenya, and KNH organizers for allowing me this opportunity to be presenter in this webinar. And also thank you to the participants who have joined in so that we can together learn about this very important and timely topic on intentional leadership to strengthen healthcare quality. So the outline of my presentation has a background, just brief, regarding leadership, the importance of leadership, good leadership in healthcare, leadership approaches and experiences, and how to motivate teams for improved performance, and then the leadership impact on quality outcomes, and a conclusion, and of course, acknowledgement. Looking at several studies that have been done on leadership, just on standalone as leadership, and also leadership in quality, in healthcare quality, there is evidence. Someone says I'm not audible enough. Okay. There is evidence that shows leadership engagement drives improvement in healthcare quality and reduces patient harm. And there are studies that have been done and documented to show this. And we've also witnessed complexity in healthcare systems as time goes by. And therefore, with this complexity, there are new challenges that require that there are new leadership skills that we need to address them. And this brings us to the context of leadership in healthcare that really has changed and has to be well designed. So just looking at understanding who a leader is and what leadership is. So it is better, it's good that we understand first who a leader is before we know what leadership is about. And a leader is basically a person who can be able to define organizational goals and vision and facilitate progress, as well as inspiring a group or a team to accomplish the organizational goals. A leader also shapes the culture of the organization that is necessary for quality to flourish within the organization. And a leader also creates a condition, or rather a model, where the team builds their culture or behavior in the organization. A leader is able to see beyond and identify opportunities to demonstrate commitment to quality in an organization. That said, it is also important to know what leadership is, and defining leadership is complex. It is also based on from what perspective or what circumstance are you defining leadership in? But most importantly is that leadership is the intention to influence others. What to underscore is the intention and also the influence of other people. So leadership is basically a foundation and a stone to foster a quality culture, and refers to the behavior that directs and coordinates the activities of a team or a group of people towards a common goal. Further, just understanding in the context of this topic, quality healthcare basically refers to the degree, or rather the probability that we can achieve the expected health outcomes, and that probability is increased in line with the professional knowledge, guidelines, standards, and basically quality definition varies across different concepts, across different programs, across different perceptions, and it's normally related with what is safe, what is effective, what is excellent, what is good, desired, equitable, or reliable. So today we are talking about intentional leadership. And intentional leadership is knowing where you want to go. So that knowledge of where do I want to go, and taking consistent action to the current circumstances to go where you want to go. It has three imperatives, very critical points: inspiration, emotion, and culture. And this has been, a study has been done on this and has been demonstrated and published by Sanborn just to demonstrate how inspiration, culture, and emotion can be able to lead to intentional leadership. So basically, it is about being visionary, goal-oriented, with a clear purpose and responsive. Allow me just to speak something about culture, emotion, and inspiration. So when you talk about culture in quality improvement and in intentional leadership, culture is very critical, and most organizations tend to make culture a HR function. And basically, culture is the force that is usually behind what happens in every organization. It defines who an organization is and who they are not. And it is basically, when we look at culture, it's like the immune system that protects the organization or a program against any variations that may occur, any declines, any abandonments, any threats that may be forcing against achieving the desired goals, anything that may lead to bad decisions. And therefore, if we don't take it as critical for the success that we require as a program, and most of the time it tends to take a backseat, then that is where the intention to take your team to where they want to be comes in. And therefore, as an intentional leader, you need to train, you need to communicate, and you need to help the team to work on that. In terms of inspiration, which starts by yourself as a leader, it is basically understanding first your purpose before you let the team to know what that purpose and mission is that will lead them to go where they want to be, or rather to achieve the goal. And usually it goes beyond just being motivated. And talking about emotional imperative, basically, when we offer services in healthcare, the outcome is that client satisfied. And it is not just about the client leaving our premises when they are happy, but basically the client leaving with the emotion that they have successfully achieved what brought them to the health facility. And so our services that we offer determines the emotion that our customers will leave the facility. So thank you for coming back. So the importance of leadership and this discussion is based on the fact that leadership and governance is one of the WHO system health building blocks, and it forms like a part of the foundation or the basic, the main building blocks that usually guides us in terms of achieving access, coverage, quality, and safety care. That will lead us to the overall goals and outcomes, which is basically improved healthcare quality that we are talking about today. And most of the time, when we are giving in quality improvement trainings, we normally say leadership is part of the principles of quality improvement, and therefore it is very critical in terms of achieving quality healthcare. Just to mention that there are different leaders in every aspect of life. And it doesn't necessarily mean that you are holding a management position to be a leader. But basically what is common about all leaders is that at the end, a leader has to have an impact created. The people that the leader served will feel that impact of that leader. And in quality, we have had several leaders. Just to mention a few, like I've selected few here. And then what is more important is that the common thing about leaders is that they are the only ones who can drive or rather root the quality concept among the team members. And Donald Berwick says only leaders can root the quality concept. So the leader's job is to ask, how can I help you improve? Basically working with the team in terms of addressing that gap between what is and what should be to reach to where the team needs to go. So we want to look at what is a good leadership in healthcare. And leadership happens when someone, by intention again, has a positive impact. That impact that the people that the leader has led will be felt. Some people seem to do this naturally, and that is why There is usually a saying that say leaders, were leaders born or are they made? And I don't need that answer. But most of us definitely can provide leadership naturally if we have the will to do that. Others can learn it, so they can be made, they can be developed, or they can be nurtured, and then they can be, then thereafter continue to do it better. So the most important thing is that leadership must begin with our mindset. So what is in our mind? Our mindset helps us to understand what we need to achieve about successful leadership. And Ross Patton points out very critical points, 4 points that hinder successful leadership. And these are things that people commonly use, that leadership is timeless. Once a great leader, always a great leader. Soft skills will improve, just give them a time. It may not necessarily be true. High performance equals to high potential for leadership. There could be very high performing people who are not necessarily leaders. Mentors are important mostly for lower levels in leading. So these are statements that when we go by, sometimes they impede, because we sit back and think that because I'm performing very well, then I have the potential to be the leader. Or if an organization wants to select a particular leader, then they would want to say who is a good performer in this particular component, and therefore tend to select that person as the leader. That may not be necessarily the right thing to do, and that is what Ross Patton is telling us. So Ross Patton also describes a leadership approach with the big 8 points, which have 3 clusters. And I picked this from the International Leadership by Ross Patton because I found it very critical in intentional leadership, and looking at the 3 clusters, the mindset, the connecting, and the personal values. These are very critical things that we need to look at in terms of identifying successful intentional leadership. And she illustrates this by mentioning about personal adaptability, which is basically being open-minded about learning and also being ready for any changes that may come about so that you can be able to address. And being strategic agility is also another aspect that Ross Patton talks about. So there are changing environments in healthcare, and therefore a good leader will have the ability to be agile. Another thing that she talks about is self-renewal. So be aware of the circumstances, be teachable, be able to learn and unlearn as a leader. As a leader, if you are arrogant, sometimes it may lead to regret, because it is good to admit that sometimes we don't know all the answers as leaders, and that will give us an opportunity to learn. She also talks about certainty of character, and maybe just to understand that character is about doing the right thing in spite of the circumstances. So keeping to your word as a leader, that is integrity. Taking responsibility, owning all the results as a leader, looking at yourself as the cause of what is happening, and being honest, and having the courage to say, yes, we are accountable. I am accountable as a leader. And of course, in certainty of character, we need to let go and forgive. Also about empathy is another aspect that she talks about. And this is basically how we relate with others. She also talks about contextual communication, the why, making people understand the context into which something is being implemented, a change is being implemented. Why this approach? Why this strategy? Why this implementation? So that the team that you are working with as a leader knows the direction that is required for them to achieve the goal. Spirited collaboration. So for better outcomes, there has to be a collaborative environment, an engagement with the team that you are working with. First, mapping out who do you need in terms of working towards achieving the goal, and then basically developing other leaders. Very important aspect. Leaders should not just be leading for people to follow. You should be able to mentor and develop other people, pick out their strengths, and so that you can be able to help them grow. And that is what Ross Patton illustrates in this, the Big 8 and its 3 clusters approach. And this, I found this very amazing in terms of addressing intentional leadership. And even just looking at the Big 8 again, in terms of spirited collaboration, sometimes leaders will need feedback so that it can be able to help us to work with the team, to work with the stakeholders that we are with. And for us to be able to also improve on our skills in leadership and to learn. So I will also share experience as from the implementation for the years I've worked and in the different positions that I have worked. I've known over time, and this is not an acronym that I've developed, I've adopted from anywhere. This is my own experience, and I call it SIPA, which stands for communicating. So basically at the beginning as a leader, you need to communicate the goal, the vision, and the mission to the team that you're working with. So that from the beginning, everybody understands that which that they need to work on towards the expected outcome or goal. And involve the team, involve everybody from the beginning, constantly engage with the team so that the team knows, it is aware, the strategies are understood. Whenever change is introduced and leaders face that challenge of addressing change all the time because of the changing environment, because of the complexity of healthcare, because of the advancing technology. So involve the teams at all levels, involve every stakeholder in whatever implementation in healthcare that is that you want to implement as a leader. And then partnership. So partnering with the team, partnering with the stakeholders in the proposed changes. Because as a leader, you won't just achieve whatever goal that you have as an individual because you have the skills of leadership, but you need the support of the team as well for you to be able to reach there. A very critical point again is appreciation. Just appreciating the little things that the teams are doing to contribute to the outcome, to contribute towards the goal, to contribute towards achieving the expected outcomes. And basically this will determine whether the outcomes will impact on the quality of care, the expected success from the customers that we are serving. So this is very critical even in our service. And most importantly, as we start, ask yourself, what is it that you want to achieve? Define the goal of the quality improvement program and the activities that need to be involved at the beginning. Who do you want to work with? Who do you need to implement a particular strategy? Who do you need to support in a particular activity? So map out the important stakeholders to achieve your goal. It's very critical that we normally think about this at the end, but it should be from the beginning. We need to map out who are our stakeholders, who are our partners. And it is also critical that we know when and where these strategies, these changes are to be implemented so that we can be able to clarify on timelines and we can be able to clarify on which activities that need to be implemented and what will we require, because timelines are critical in terms of even evaluating whether your leadership skills have impacted on the outcomes. And therefore it is critical. The how are very clearly, how will you be able to implement them? What are the strategies? How is the capacity of your team? And I remember mentioning that a team needs to be in the 3 imperatives. A team needs to be communicated to, a team needs to be capacity built or trained so that you are able to keep them at pace with what they are supposed to implement. The team needs the tools that are required. So at the beginning, organize what are the tools that we require? What approaches, what strategies are working in the changing environment, in the current challenges in healthcare? And these approaches are required for us to be able to achieve our goal. So the what, the who, the when, where, and the how are very important in leadership. And these are the things that have been really important in my experience in the healthcare practice. So I just wanted to also demonstrate as a program some of the leadership approaches that we have implemented, and we have seen this working over time. So we work closely with the Ministry of Health in terms of supporting the HIV care and treatment component in programs. And so we work directly with NASCOP as a national arm, as well as the Department of Quality at the national level. And of course, working with the counties, because our implementation is at facility level, and we also have some above site activities that we do implement as an organization. So we work with the chief of executive committee members at the county level, the COHs, the CDHs, and at this level of the county, one of the structures that we have worked with the counties to establish is having county quality improvement teams, as well as cascading this down to the sub-county quality improvement teams. And these structures are really supported in terms of implementing and cascading quality strategies to ensure that we achieve the desired health outcomes. And of course, just to bridge and also to ensure implementation, at the county level, there are usually county quality improvement TWGs where partners, stakeholders, and even this includes the communities and other represented by clients come together and discuss strategies and plans to address quality issues at the county level. And of course, now moving down to the sub-counties where the committees on quality discuss matters quality and also the quality indicators and also the strategies, and rolling out and implementing the quality guidelines and framework. And this is now cascaded down to the facilities where the quality improvement teams have their respective roles, and down to work improvement teams, and even up to the community. So at every level, there are defined roles, and this is very well guided in the National Quality Improvement Framework and also the Kenya Quality Model for Health, and of course, even the NASCOP Kenya HIV Quality Improvement Framework. And so this guidance in terms of leadership has really enabled us to address quite a number of quality issues, and even just working on improving the quality outcomes. So as a leader, we have a role at all levels in terms of achieving effective quality health programs. So an intentional leader works at all levels of service delivery in quality health programs, starting with the use of data that usually informs what kind of, what are the outcomes, what is the performance, what is the level of quality that we are offering to our clients. So using data, it will be able to help you as a leader to clarify to the team what is the aim, starting from what the data says. And with the use of data also, as a leader, you consistently assess progress towards achieving that aim. And so it is easy for an intentional leader to monitor progress using evidence, using data that is available. And this will help even facilities to learn and embrace improvement. This usually addresses resistance to change because data speaks and is able to demonstrate what is happening. In terms of system thinking and in quality improvement, we approach the health programs as a system. And for us to be able to overcome the inertia in the present health systems, it is always good to approach a quality issue as a system. Basically looking at what needs to be put in place in terms of structures, what needs to be put in place in terms of processes to be implemented, and what is expected at the end as outcomes. In terms of developing changes as leaders, be present, have the new knowledge that is there, have updates so that you can be able to inform the team from an informed perspective. So that whenever there is an idea, even programs we have in the HIV programs, every year we have new strategies, new paper strategies. So with this, we live as an intentional leader, you have to live in the present. You have to know that is expected at that particular time so that you can be able to help your team to develop changes. In terms of testing and making changes, it is good to allow teams to have an approach where they can appreciate the small steps, they can experiment, they can implement support structures based on what they have identified alongside the implementation period. And you have to be present and offer consistent support so that change is implemented and you are able to help the team to demonstrate that these small tests that you have implemented have actually resulted in improvement. And of course, lastly, collaboration is a very critical role, basically to develop and inculcate and reinforce a sense of common purpose. So working as part of the team so that there is a teamwork felt by the team that you're working with. So as we move closer to the end, again, motivating teams for improvement. And this is a slide that I just borrowed several things to demonstrate what has happened in the experience. And of course, we have consent from Nairobi County to use the photos. Others are from Kisumu County. We also got consent. So because of the developed structures, leadership structures at the county level, you can see a function that is being held at the county and being led by the governor himself, owning up and being part of the activity. It's a motivation, one, to the healthcare providers to support, to enhance quality of care. It is also a point of showing that intentional leadership from the governor and also the director. And even this was an activity that was organized by CHEP in collaboration with by the county in collaboration with the Nairobi County partners. And we can also see the presence of the senior leadership in programs like the CEO for CHEP Kenya. So this kind of intentional leadership is what we want to see in order to achieve quality care. And as you can see, the small things of appreciation, certificates for good performance to the teams, make those happy faces. They leave going back to the facility motivated to be able to serve that client with the energy and with the power and with the knowledge so that they can be able to experience good outcomes. So I just wanted to demonstrate that motivation does not just mean maybe giving incentives or maybe doing very big things, but those small appreciations to the teams may really impact in terms of improving performance. So just some of the improved outcomes that you have seen over time as a program. In terms of quality of care, we have seen improvement in the different counties that we have implemented across the first, the second, and the third 95 in the HIV programming. And we have also seen improvement in institutionalization of quality improvement approaches. So including sustained TWGs and functional quality improvement teams with structured meetings. So this basically means that quality healthcare can be sustained with improved leadership. And to demonstrate this, just a little bit of data just to demonstrate the different indicators and how they improved through quality approaches over time. So this is just a bit of demonstration of some specific quality of care indicators that were being tracked by the teams through SQH projects that were improving over time with the guided leadership. Yeah, similar to this. And so my conclusion is that intentional leadership is about the routine procedures based on the experience and anticipation to achieve zero harm to the recipients of health services. So we can purpose to be intentional leaders. And I want to acknowledge the Ministry of Health, the counties that we work in, the facility quality improvement teams, CHEP Kenya programs, University of Maryland, CDC that supports through PEPFAR, the programs in the CHEP programs, and of course, Acquire for giving me the opportunity to be the guest presenter in this webinar. Thank you, and over to you.
Amazing, amazing, amazing presentation, Violet. Thank you for that wonderful presentation. Teams, kindly let's give electronic claps, electronic likes, electronic emojis to our first presenter for this afternoon? Are you an intentional leader? I think that's a question you need to ask ourselves even as we move on. I was to move to the next presenter. I mentioned earlier that we have 3 presenters this afternoon. So our second presenter, let me introduce to you our second presenter, Sinaida Mulumba. And even as we get the slide, allow me to take you and just give you a brief bio of Sinaida Mulumba. Sinaida is passionate about quality and efficient systems where quality culture is embraced across all staff in organization. She is the quality assurance manager at St. Francis Community Hospital. Her role is coordinating quality and patient safety and regulatory programs to maintain a systemic, continuous team-based approach to quality and compliance within the hospital, ensuring the hospital accreditation and certification program, for example, ISO Safe Care, are successfully implemented and maintained. She develops, implements, and monitors and evaluates all aspects of the hospital's continuous quality agenda. She spearheads acquisition for ISO accreditation for the hospital, collaborates with management staff, between consultants and all the teams in ensuring quality within the hospital. Previously, Sinaida worked as a contact person when she was in Life Care Hospitals with Farm Access Foundation in successful implementation of Safe Care Standard and participation in QHKA Awards in 2021. Credentials, Sinaida is registered clinical officer with a bachelor's degree in project management. She has 3 years experience as practicing clinician, 5 years in quality healthcare. She is also a trained lead auditor for ISO 9001, 2015 from SGS Kenya. Ladies and gentlemen, allow us, let's welcome Sinaida to give us the next presentation. Karibu sana Sinaida.
Good afternoon, team. Thank you, Jennifer, for the presentation and also for the opportunity to be in this platform. I will go straight to my presentation, which is the role of leadership in patient experience. But before I go into that, I'd just like to give a brief introduction about St. Francis Community Hospital, which is based in Kasarani. So to start us off is to share some background information about the hospital. It was founded in the spirit of St. Francis of Assisi, who is the patron saint of the hospital, in order to give special attention to the poor and the needy by attending to their spiritual, economic, and human and intellectual needs. And so it's owned by the Little Sisters of St. Francis. The hospital is located around Kasarani, Muki Road. As you go to Muki, you will find there's a big billboard. There's a big signage showing or it's St. Francis Community Hospital. So the vision and the mission of the hospital, the vision is to be the preferred Christ-centered, evidence-based, affordable, and efficient patient-focused specialist healthcare in the region through sustained targeted healthcare system development. We have a vision, which is to be the preferred epitome of high-quality specialist healthcare within the region. So we also have core values that guide the institution, which is love of Christ, honesty, integrity, committed to Catholic Christ ethics, and efficiency and effectiveness, and also committed to excellence. So I'll briefly now go into my slide of leadership in patient experience within St. Francis Community Hospital. So as a facility, we have engaged and embarked on serious patient experience initiatives within the hospital. which are spearheaded by the leadership of the institution. Of course, we have in mind patient safety and experience of the patient while they are still in the facility. So all decisions are made around ensuring that patients are satisfied. And even as we interact with our staff in the institution, we ensure that they put it also at their forefront in terms of handling patients. As my co-presenter has mentioned, that experience is key in ensuring that patient satisfaction is attained at all levels. And also she mentioned about expectations of clients. I think it's different for everyone because some come in expecting just to get a good overall experience, to be treated well. Others come because they want to achieve quality care. Others come because it's effective or they will spend little time on that institution. So all these expectations are different from every patient. And remember, they're coming into one facility where they expect to find all these things. So as the leadership of the institution, try as much as possible to ensure that staff are well versed and well aligned to these different varieties of expectations. So alongside this, we have set goals and within the institution with targets. We have a customer satisfaction index of around 90 across board, both inpatient and outpatient. So most of these ways of which we help to ensure is we have a measuring scale, and in my next slide we'll be looking at how we've been performing in the customer satisfaction index. And also setting goals is done by the organization and it's also part of the strategic plan to ensure that we meet and exceed the expectations of our customers. And we also understand that if we are to achieve these goals, we have to really engage our staff in all these activities and initiatives that we have put in place. And staff engagement is all about training and encouraging the staff across board, because there are some who feel like as long as they're not putting or they're not in direct contact with the patients, they don't have value in terms of dealing or handling this patient and creating a better experience at the end of this patient stay within the institution. So we have a way of engaging all of them in terms of even merging and engaging them in creating initiatives. Some we involve them in going out for outreaches and just creating that positive experience with the patients when we're going into our outreaches. So we create the teams that all of them are comfortable in so that they can all be participants of creating the overall patient experience that we expect. And also this comes in line with setting up our culture. I heard Violet say that some organizations think that quality is a HR function, culture is a HR function. But if you want to establish all your goals and have a good trend or a good upward trend, all members, all staff have to be onboarded onto a good organizational culture of which supports the organizational overall goal. And for this, we always inculcate the culture of good experience to our patients, and also try to communicate this across board, especially when you're having meetings and all that. We have to sit down and preach the gospel of how they're supposed to attend this. So we have a customer satisfaction course, which we sat down as an institution and looked at how we would want to monitor our customer satisfaction index within the hospital. So we had remodeling and restructuring of how we would want to do all this all together. So we came up with a tool in June 2022, and the tool was launched first in person. We tried to automate it, but it was still not possible because we needed real interaction with our patients. So we came up with with a feedback tool to the patient, which is given at time of discharge, and they would score on each and every aspect of service that was given to them while they were in the hospital. So we experienced a good turnout because when we initially launched the tool and everyone was all about giving the feedback, and we analyzed it and we actually had a good score then. But then going back to, sorry, could you kindly go back to the last slide, please? Thank you. So we had a flow of up and down in the initial stages because we're still looking at how best we could strategize and get accurate data from our patients. And this came in about trying to teach also the staff on how to get the feedback back to them. Because when you collect feedback and don't share with the direct persons within the department, then they will go not knowing how they perform. So the orange line depicts the OPD customer satisfaction scores, and you can see we have a gradual upward trajectory on towards the target. And in between we have the low peak season, low peak trend, because we had a point where we had to look into separating the feedback in OPD and having to have the different service points to have their individualized scores. And that is when in this department we had to bring in more training, more being more aware of how to close their feedback and how to create a positive and good patient experience to the patients in their point of service. And then we also realized that we had not looked into staff satisfaction, and we did it around late April, and we started seeing an upward trend now in improvement of our patient satisfaction, because part of the patient experience is pegged on the staff engagement. So if staff are not happy, there will be a ripple effect to the type of experience your patients are having. If you're having a gloomy staff, then you'll also have a gloomy or a sad patient in the end. So this is some of how we were able to achieve our target, and we just have some few challenges that we experienced in the process and some gains. So we had low feedback reports in the beginning because our outpatient feedback tool was integrated into the system. So initially, we had high feedback from patients, but I think the tool was too long for them to feel towards the end. So we came up with a way of now trying to call some of the patients and sample out. At least if in a day you're seeing 200 patients, you'll make a point of calling at least 10% of that number to get feedback, but also involvement of patients, getting patient feedback on a daily basis by the customer relations as they interact with patients in the OPD area. We also had a baseline of reports. I mentioned we had to separate the departmental reports so that we can make it more focused, and also came up with a root cause analysis form for all the feedback, which the departments are sitting on a monthly basis to discuss on ways of improvement. And we also had organizational silos where there was no proper communication in between the different departments. When you sit down to meet a specific group, maybe it's in a quality improvement meeting, not all the departments are involved. So the departments in which members are not available, you'll always find that they always lag behind. But it is a matter of now the leader and the one in charge to go around and ensure that they are all up to speed. So one of the gains was doing the staff satisfaction survey. We were able to understand some of the challenges our staff were facing and try to solve them as an organization. Also, our way is to empower and train staff. We train them, and on the feedback report, there's a place where patients can communicate and say, and actually acknowledge the specific staff who did good or who created a positive and good experience for them. And this we always go on mentioning whenever we are gathering in a meeting, we always applaud by word of mouth, encourage them to continue doing the good work, and as well as also improving the awareness and patient experience. So these are just whenever we are communicating or having CMEs, we'll always have announcements or ways in which we communicate to our fellow staff on good patient experience and what we would expect them to do in terms of that. Yeah, so that will be the end of my presentation. Thank you.
Thank you so much, Sinaida. That's an awesome presentation you've shared with us. Leadership has an awesome and a very pertinent role to play in patient experience. Thank you so much for sharing that with us and what you've been able to do in ensuring that patient experience is improved. Allow me to bring our next presenter. And our next presenter is Dr. Lucy Florence Ngugi. Dr. Lucy is passionate about improving healthcare policies and strengthening communities and facilities in making healthcare effective, affordable, and accessible to all. She is currently technical assistant to the Nairobi City County Executive Committee member for health, wellness, and nutrition sector. She is responsible in providing technical support to the office of the CECM. Dr. Florence was a medical superintendent at Jenga Level 4 Hospital located at the heart of Mukuru kwa Jenga. In terms of credentials and education, Dr. Florence holds a Bachelor of Medicine and Bachelor of Surgery from the University of Nairobi. She is also an ongoing student of Masters of Public Health at the Amref International University. Ladies and gentlemen, help me in inviting Dr. Florence to take us through the next session. Welcome, Florence. Thank you.
Thank you so much, Jane. Good afternoon, everyone. My name is Dr. Florence Ngugi, as you have heard, and I am really excited to be part of this conversation. Yeah, so karibuni, and I think we can start, Jane. Yeah, so I work for Nairobi City County. Nairobi has population of around 5.5 million Kenyans. So most of my discussion today is going to be based on our experience at Jenga Level 4 Hospital. I recently moved from there. So Jenga Level 4 is located in Embakasi South, to be specific. Embakasi East and South has a population of around 700,000. For Embakasi South specifically, we were serving a population of around 390,000 Kenyans. Currently, the area is served by 10 public facilities, where there are 2 level 4 hospitals, with Njenga level 4 being one of them, and 3 health centers and 2 dispensaries. So today's conversation has been very interesting with Violet and Mulumba. So as being the last speaker, I think it's a Tuesday afternoon, almost 4 p.m. I'll take an approach of giving you all our story, and hopefully from there we'll be able to pick a few leadership strengths that we got from there. Yeah, so can go to the next slide. Yeah, so as indicated there, this is going to be purely a Njenga level 4 hospital story. And so I put that there. The true north is always the patient. One of my very important mentors in this journey kept reminding us of this, that when you don't know what to do in the healthcare system, go back and ask yourself, how is this supposed to impact the patient positively? So in 2021, at the beginning, the county leadership and sub-county leadership came together and posted me to Njenga Level 4 hospital. At that time, I think I only had almost 2 years experience in the medical space, mainly in the clinical setup. So when I went there, I'll say the truth, I sat in that big office with a nice chair and a nice desk and nice dispensers and cabinets. And I sat there feeling very clueless and not knowing what to do, where to start. And the only thing I knew was that I wanted to participate in the smallest way possible in being part of the solutions for the patients in that area. Specifically, this hospital is located in Mukuru kwa Njenga. It's truly at the heart of the slum. So I sat down and we had a team of around 40, 50 staff. I invited all of them and we used this approach. I told them, you're my brothers and sisters. We're going to sit and look at the current situation. At that time, the facility was a level 3 health center, had not yet been upgraded. So we said, this is the strategy we used. We said we will analyze where we truly are, what is our situation. We will look at what challenges and complications are we having to where we want to go, and what actions are we going to take together as a team to move this facility to a point where it can serve patients better. And of course, what results are we looking to have, so that again, we can come back and ask ourselves, we set this target, how are we doing in a month, in 2 months? Because as alluded to earlier, you have to have a way of monitoring whether you're actually having an impact in the growth. And so what indicators are we going to look at to determine whether we are growing and whether we're improving? Yeah, so these are the key areas we looked at. So that same approach, we started with finance, being a level 3 facility, which was new. The accounts read 0, meaning there's nothing really we could purchase. We were totally dependent on the user fee forgone, which sometimes can be a bit inconsistent. So we agreed that our number one challenge was that we had 0 money. And our number one complication is that we could not charge because we were at a level 3 facility by that time. And then we decided the action we are going to take as a team is, number one, we'll set up NHIF Linda Mama offices. So that began our journey together with we appointed HODs, one for patient, one for maternity, one for maternal and child health, one for special clinics, and another one for the kitchen and laundry area. So we started with NHIF Linda Mama. It looked like a very small step at that time. So every morning at 9 a.m., together with the deputy, we would sit, and one would sit in the office, the other would go to the branch office for NHIF to follow the licensing. And within a few, like 2-3 months, we had our license, and now we could start claiming Linda Mama funds from maternal and child health and maternity. So the impact of that is that I will go to where the result took us, is that within 1 year, actually within 6 months, by December of 2021, we had generated around 1 point something million. which now brought another complication that we had to chase this money and make sure it's paid. So it was paid within a month. So I will jump to point 6, community and stakeholder engagement, in that now we learned that we have to apply a lot of support from the political goodwill, which is the leadership of the area, the members of parliament, the MCAs, the county leadership, just to get reimbursements done. And then when their support came in, the first batch of money came in, and when you hear the Bible say money answers all problems, the story began to change, because now at that point we could be able to afford things like point 4 commodities. So let me go back to point 2. Even as you look for finances as a strong arm in the health system working, we also had a challenge that patients were not coming to the facility. And we sat back again with the team. We asked, why do we have such low numbers? Why are we having 15 deliveries in a month? And we have someone on call every day. Why are we only having 10 patients in our outpatient department in a day? Why are we having 6 mothers coming for antenatal clinic? And so we identified our issue there. Number one, we didn't have a strong team. Everyone was just doing their own thing. So we started developing a culture of teamwork, of course, with the support of partners like Violet's organization, CHEB. They would come and do on-job trainings for us. We started a culture of doing CMEs every week. That meant we would meet every week together and just keep growing the team effort and the teamwork, and keep reminding ourselves where we want to go. We kept saying we want the facility to be a diamond at the heart of the informal settlement. So we put together the HR with the assistance of the HODs, of course. It had to be a lot of support from different levels of staff. And then also we realized, other than that, even if patients, so we decided there's an important part of our staff that we had ignored, which is the community health workers. Now they're called CHPs. So this was actually an advice from one of the HODs. So we each removed 1,000 bob. We bought soda and bread, and we invited the 120 community health workers attached to our facility. We didn't even have benches for them to sit. So they came and we sat on the grass. And I hope as I give this story, you can pick the reality that you don't really need so much. You only need to know where you're going, the true north, which is to serve the patient, and to be able to have a team, because we kept reminding each other at the facility that if we are a team of 5 team leads, for sure we have 5 strengths that we can derive from. Yeah, so we sat with the 120 of our community health workers and we asked them, what is going on? Why aren't patients coming to the facility? And as we were taking the kadudu soda, the small ones, that's what we could afford, they started opening up that first, patients don't know that there's a facility here. So we had one action plan. We have to do marketing. And marketing, when you hear marketing, you think it's money. Sometimes it's just waking up one Friday and going and walking in the Kijiji and inviting patients to come to the facility. Yeah, so the other point we got was we didn't have a road, so patients couldn't access the facility. So I will jump to point number 5, infrastructure. When you think infrastructure, it's not just the building, because we had a very beautiful building existing for the facility, but there was no access road to the facility. So we sat down again with the team and we said, we're going to look for the community the political arm of leadership and the community leaders. And we came together and we all lobbied, and we got an access road within around 8 months of deciding to do this. So again, mark this step, because now even at night, it meant that patients could come to the facility. We coupled that with lighting, because now it was very dark. It's in the middle of the slum. Patients could not get to the facility. And then we got partner support from people like CHEB, UNICEF. They donated mass lights for us. Others gave us, I think UNICEF gave us 10,000 liters containers for water. We had backup water, and so we didn't have water issues. Then the other thing we got from the county leadership is we were given a generator, because again, from involving our community and looking for feedback, we realized when lights go off, when the community people tamper with the transformer, the lights go off for 2 days. If a patient comes to deliver at night, you have to suture with a torch. So with the help of the team and many, many other people, especially support from the county government of Nairobi, we were donated for a generator, which now transformed our story. It made now our facility be able to operate 24 hours, coupled with teamwork for the HR, because also you can have a generator and staff are not motivated to come to work. So those two worked together to allow us to be the only level 4 facility that was offering 24-hour services. The other thing we found out that we needed to work on was the equipment. So number one, everything was everywhere. On the next slide, there's the image of the 5 S's. Everything was actually everywhere in that facility. So we started with the HODs. We picked one day, a Friday and a Saturday morning, and we sorted out all our equipment. We identified a room. We realized what do we need, what don't we need. We sorted it. Then we decided now we will set this, the machines that are not in use, we'll put here. The equipment that are not in use, the commodities, we'll do this, we'll shelve this one will go to the store. Then we agreed as a team, we came up with SOPs on how we are going to maintain our inventory with the S11s, that time we didn't even have the right documentation. We had a black book where you would fill, if you remove a box of gloves, you write, I have removed one. We didn't have bin cards at that time. So you can see it's as basic as it can get. You can actually have an impact in the smallest ways possible. Then we standardize this with SOPs. And because now leadership is about motivating fellow brothers and sisters to walk this journey, to walk this vision together, it outlives even your presence. Because as I alluded to earlier, I'm no longer there. It's been 3 months I've not been there, but they're still doing well, because we're able to come up with a culture that can be sustained, and SOPs that really are not person dependent, but are vision driven. Yeah, so if you can go back again to the other slide, so the equipment issue, we realized, so after we applied the 5S and sorted out our inventory and our commodities, now at least we didn't have a cluttered facility. Even in an emergency situation, we had an emergency trolley, we had an organized facility. So now the numbers start coming in. With all these factors working together, the numbers start coming in and the staff start getting stretched. You're moving from 1,000 to a workload of 2,000. You reach 4,000, you're doing 8,000 with the same number of staff. And now you start feeling the stretch. So again, we went back to the county leadership. They boosted our HR numbers. We got a couple of nurses. We had 2 MOs. There we had around 6 clinical officers posted in. And so now that continued to grow. And I think at the time I was leaving, they were hitting 9,000, 10,000. every month, patients every month workload. Yeah, so the other thing we picked there was again, the vision has to be targeted. And I'll give an example. One of the things we noticed together as a team is in maternity, we want our numbers to grow from 15 to X number, but you realize we were missing critical ingredients to this. So if numbers are coming in, so we applied our finances well. We lobbied to get our staff trained and capacity built on procurement, on how to handle stock taking and all these things. So, for example, we didn't have an ultrasound. Now here, I'm trying to allude to the point that your intentional leadership has to come with creativity. So we realize we don't have an ultrasound machine. All our mothers come. We don't even know whether they had twins. We discovered during examination at admission. You query that during admission. And we didn't have the money. So there's a neighboring facility there that had an ultrasound machine. And we came together with our small finances. We planned our finances per quarter. We sat together and we said, this year we are doing a work plan and it involves XYZ. And one of our key areas is we need all our mothers to have an ultrasound done. If we are claiming Linda Mama NHIF, we have to apply it back to our patients. So we looked for a utility car from the county, and we would transport this machine every Monday to Njenga level 4, and we would give free ultrasounds for all our mothers. The question of sustainability comes in, but let me tell you, with a team, there's nothing you cannot do. If you apply these community partners, all the political goodwill, our money was streaming in very consistently. So we said, if we are going to be reimbursed 5,000 for every delivery, we will take away half of it to make sure our mothers have ultrasounds and they have a full ANC profile for free from the reimbursements. So if you go to Njenga level 4 right now, every Monday, Tuesday, Wednesday, and Thursday, mothers come and get a free ultrasound. The county supported us. They posted a sonographer in the facility. So we didn't have to pay for the HR. And now what that meant is that we could do around 400, 350 mothers scans every month. And you have no idea how much that changes your outcomes and the quality of care you give to these patients. And then every mother who would attend ANC would get a free antenatal profile. The whole list, urinalysis, RBS, VDRL, using the finances we were claiming from Linda Mama. And now what that does is that it boosts not only your numbers, but also the outcomes you get during delivery and the rest. And this is a list of achievements. I don't want to belabor you with all this. Basically, the point I would like to share today is that leadership, you don't have to sit in the big seats to have an impact. You can have an impact even in the smallest ways in your facility, even if it means starting an NCD clinic. Like there, we started one. By the time I was leaving, they had around 200 patients with partner support. They were getting subsidies for medication. And you can see that will send a ripple effect even to the next generation. So it can be done even if in the small ways, even if it's in your clinic somewhere in the middle of a slum, you can actually have an impact. And if you work together with the team properly and to just continue to learn and to improve your skills in sessions like this, we can actually make a difference for the healthcare system in this country. Yeah, so I would like to show you one of the graphs we had of our deliveries. We started actually at 15. That was in 2021. And you can see they're doing above 100 right now. And that is the goal really, so that the healthcare quality affordable healthcare is not just available to the privileged, but even to, if we put to good use and if we lead with intention and with courage, we can actually have an impact in our communities in the smallest way possible. Thank you so much for giving me your time, and God bless you all.
A big thank you. Awesome presentation, Dr. Lucy. I think that's amazing work happening at Jenga area. Thank you so much for that wonderful presentation. I think you can all see the role of leadership. Irrespective of where we are, there's a lot we can do through leadership to make sure we are able to deliver quality care to our patients. Next, I think we have an opportunity now for us participants. We want to get to hear from you through a poll. So at this point, allow me to invite Jean to present a poll. So we are getting a small poll, just a quick poll, after which now we'll move to our Q&A. But let's get the poll first. So Jean will share with us. Participate in the poll as we move on.
I hope you're able to see the poll.
But the buttons are not working. Okay, or the host and panel cannot vote. It's okay. I guess the others can vote. No problem.
So Jean, I think some of the panelists are not able to see the poll. So once it's done, I think you'll be the one to tell us about the progress because we can't see it. Kindly.
Yes, I will share. Please remember to only choose 3 topics for the first question. Okay, we have 1 minute left.
Keep your votes coming in, or rather, you answer our poll. We are about to close in the next 30 seconds. Final call to give in your poll results. We are about to close. Thank you to all who have voted. We are closing the poll now. To our panelists, we are currently displaying the results of the poll. Should be appearing on your screens.
So thank you so much, Jane. Thank you so much, participants, for participating in the poll. I know our Acquire team will be talking to us about the same as part as we go by before we finish this webinar today. Kindly feel free now to post your questions in the chat, and we'll be happy to respond them to you. Allow me to check the questions we've received so far. Kindly keep them coming. We have a question here for Snyder. Do you mind sharing your tool for customer experience? Before you respond to that, allow me to read another one. Hello and thank you, Snyder, for the presentation. A good high opener. However, I've noticed a drop on the cluster feedback graph. Do you use a specific line feedback mechanism or a combination or of different ones? In the case, how do you tell which mechanism was able to capture customer feedback? So Snyder, I think we have a question for you. If you can comment on the tools you use for customer feedback, and also if you can comment on sharing the customer experience tool. Snyder, kindly.
Thank you for allowing me to respond. Yes, I would share the customer experience tool that you're using. So the one you're using, we customize it to our institution. Yes, we have different modalities of getting patient feedback. We have one for outpatient and another for inpatient. We have tried to use that one for outpatient and put it online, but we realize it is not, patients are not willing to go through the whole feedback because it's a different service point, and we wanted to synchronize it in our system such that it will only spit out the specific service points that the patient visited, but that is what we are currently working in progress. So currently the one we are using is the same one, but we are now taking the patient through on a call. So a call will last at least a maximum of 3 minutes, looking through the questionnaire. But we also have the daily feedback that we receive on a daily basis from the customer care desk. So all our patients who have concerns are directed to the customer care desk, and complaints and concerns are registered. So there are some that we pick up on a daily basis, and some we have a dashboard that we monitor and escalate to the responsible persons to which the complaint concerns falls under. So we have like every day we will receive those feedback and analyze, and at the end we'll review and see how many we managed to close within the time frame, which is within 30 days. But we have specific timelines allocated, because when you allocate someone a concern, they'll have to give you their timelines on when they think they would be able to close it. So it's a combination of team effort and a prompt escalation of the feedback. And the ones that are sorted immediately and instantly are sorted by the customer relations team. Thank you.
Thank you. Thank you so much, Sinaida, for that response. Let me move to our next question. And our next question is on is for Dr. Florence. about your activities as Ponjenga. Thank you so much. So the question is, just give me 1 second. Dr. Florence, you do not have to sit in the big seats to have the impact. Great takeaway for the team. Thank you, Dr. Florence. I know there's one question for you also. Thank you for the presentation. Kindly elaborate some of the strategies you used to increase the number of deliveries. Dr. Florence, if you can kindly respond to this one, the strategies you used.
Thank you so much for that question. So number one was we capacity built the staff so that you don't get patients and your staff don't know what to do. So we started doing CMEs. We worked with the sub-county and the partners to do drills at least every 2 months. Then we would look for trainings around the county. If there's any on RAMCA, any emergency, any training related to maternal and child health, we would really prioritize that. And then also the MPDSR meetings, in as much as we didn't have mortalities, sitting every month during the maternity meetings and reviewing our critical patients and coming up with strategies, again with the team, because it has to be a team effort. If you have a team of 15, 16 nurses in the maternity, there has to be a change in mindset for each of them. And when you capacity build them, you build the confidence that now they can induce. So our 2 medical officers really helped because we would go and get our hands dirty. We teach them, the nurses, how to even do procedures they were afraid to do. Then the other thing that really improved was we introduced food, as simple as it sounds. We came up, we sat with the sub-county and county team, guided us, the nutritionist. We came up with a timetable where we would, considering Njenga is in the slums, that was an incentive for us. Mothers knew if they come to Njenga, they'll eat chapati, they'll have rice, they'll have breakfast, they'll have uji. Of course, we staggered it so that, of course, we introduce meals the right way after delivery, but we'd make sure our patients eat and eat good food and consistently. Then we introduce small things like hot showers so that mothers knew if they come, they'll have a good experience, making sure the maternity is very clean. And then we introduce also an SMS program where at discharge, we would get their numbers and formed a WhatsApp group. So, for example, October mothers had their group with our nurses in that group and the HODs, and then we would ask them to give us feedback because, of course, we didn't have the finances to come up with a tool. We used WhatsApp and just asking them what was the experience, and would retain the groups for them to ask us questions even in the postpartum period. The other thing that really changed things that came later on with, of course, as we generated more money, is the free ultrasounds and the antenatal profile. That worked, it did the magic truly for us because, so if you're doing 400 free ultrasounds in a month, of course, this mother gets to come experience your facility. And during those ultrasounds and during antenatal clinics, we would take 15 minutes and take our mothers around our maternity and show them around, show them our clean services. So the HOD for maternity and MCH came up with a list. Every day there was someone who was assigned to take our mothers around and to answer their questions and to encourage them to come and deliver in our facility. Those are a few of the things we use, but of course it was really a team effort to engage the community volunteers also to just bring patients to the facility. Thank you.
Thank you so much, Dr. Lucy. I think that's an awesome activity you are doing there. Thank you for the response. Team, allow me to take the last question. Just keep the questions coming. I think our presenters will be able even to respond to them in the chat as we put them on. But at this juncture, with the interest of time, allow me to read our last question. This is from Caroline Osudwa. Certainly a big question on leadership and quality. How does effective leadership contribute to and ensure high quality outcomes in organizations? And what are the key principles and strategies for achieving this? I think I'll ask one of our panelists, Dr. Mary Adams or Dr. Okutoi. Maybe one of you can respond to this kindly.
I think Violet can respond to that one if she's still there with us.
Violet,
yes,
kindly.
Dr. Okutoi, I'm here. Yeah, thank you, Caroline, for this question. And clearly, after listening to Dr. Lucy and in that experience from the presentation that we discussed on intentional leadership, I could say she is an example of an intentional leader. And looking at the SIPA approach, which we discussed, that includes communication, involving, partnership, and appreciating. I just want to use that example that is very fresh, in that from the beginning, she had to apply the how, the where, the when, the who, and the what principle, so that she's able to clearly outline what is it that she needed to achieve at the end. And now she went to communicate to the staff, just to get their views. And that is the aspect of communication and involvement, and further reaching out to the community, who are the recipients, or rather the part of the stakeholders. And we could even hear her speak about the Ministry of Health, the MOH, the county, other partners in the region. And through that, she demonstrated data that later actually led to inflow of resources. So she couldn't struggle with resources because she was able to be supported. And the last aspect is just staff being, feeling that they are appreciated in terms of making their work environment conducive for them to be able to work towards achieving the intended goal. So I could say, the aspect of just understanding from the beginning what is it that you want to achieve is a very good principle of knowing what successful leadership is about, and of course applying the SIPA approach, which is not anybody's invention. It is just my own intervention that we have used as a program. Thank you. I think any other panelists can feel free to add. And maybe just to read further on the Ross pattern model, also there are very good insights on that. Time could not allow us to just go through everything. Thank you, and over.
Thank you. Thank you so much, Violet. That was an excellent explanation. Dear participants, kindly allow us to close the Q&A at this particular section. However, your questions will still be responded by the panelists as you continue posting them. Allow me at this juncture to invite the Acquire team to give us an announcement, after which I'll call on the KNH research team, but also give us a notice. Acquire team, kindly.
Thank you very much, Jen. I think allow me to just appreciate the great presentations by Violet, Snyder, and Florence, and for your great moderation. You've made us get some great insights, and so we will try to listen to this again and again. There's something fresh about the theory or the cognitive being applied on the ground. And so both Snyder and Lucy shared what you've done, and similar to what Violet was able to share about even CHEB, their programs. So quality and intentional leadership makes a difference. It enables the quality of care to flourish. So a short announcement from Acquire. So this webinar was enabled by KNH hosting us, and this is a Society for Quality Healthcare series on the healthcare quality series webinars, and they have been here now. I think this is the 3rd month, and we truly appreciate you showing up, and it's been a time of growth for both the participants and the speakers as we share. It's said by teaching, so you learn. And so I guess even Violet gets better today, similar to Florence as Snyder, just by doing this. And Jane, who does quality at MPSHA, by just being part of this, we grow. So we truly appreciate. And to this effect, Acquire, as you can see projected, is planning to have a quality improvement, a one-on-one short course. It will last 4 days and having afternoons. And so part of the poll was to find out, would you prefer them to be back-to-back, Monday to Thursday, or would you want us to space it one afternoon per week for a month? And so we will get back to you. But for those who are interested, you can go to the chat box. I hope, Jean, you can post to everyone. Those who are interested to get further information, you can get information from a link that will be shared on the chat box. And if you get the information, you can as well exit that space. So it will be a free course, an introduction to quality improvement, virtual, non-experiential. In the future, I know SQH, KNH, and even Acquire will have experiential courses whereby you can go through mentorship, and you can also have a project and but this is virtual, and so it is accessible to anybody across the country. So we hope to do this in January, but you'll get further information. If you're interested, you can join that link. Allow me to appreciate the KNH, the leadership of KNH, and the KNH Research Department for hosting us today, and also for us continuing having the banner for improving the quality of care in Kenya. And so our institutions, our people who come to Mukuru, Kwanjenga, those who come to KNH, those who come to St. Francis, and to the hospitals represented here, they should be able to rub on this momentum that we get from these spaces. I think, allow me to hand back this over to back to Nelson, and to appreciate the Society for Quality Healthcare Education Committee that plans and organizes this series at the background. Asanteni sana. Do have a good evening.
All right, thank you, Dr. Kutoi. And thank you also, team, for the wonderful presentation today. I think we have gained a lot from the series that has been on this platform. And for those who are interested in the course, a link has been posted in the chat box that you can just click and follow. And we will be following up with a follow-up email to those interested, so that you can also receive the link on your emails and you can be able to access the short courses. Mine is just also to thank you once again for joining us. We'll be back again today evening at 7 with the pediatric diabetes series, and we'll be continuing and looking at exercises for children and adolescents at school and also at home. Thank you once again, and do have a wonderful good afternoon.